received like nameplate necklaces that say.
Oh, that's such a good. We said when we go to AAP, when PM&R is live, like we want to have shirts for people who've been on it.
Yeah, it's like your whole brand.
Well, we have a treat for y'all this evening. Today's basically our second half of our spinal cord injury discussion. Last week we had Dr. Bruman and Dr. Skelton talk about what it's like practicing spinal cord injury medicine in the VA. And today we have two of our attendings. They were our residency. When we were in residency, they were our attendings at Baylor in Dallas. And so Dr. Sikka joins us and Dr. Daun Chung. And they are going to be talking a little bit about spinal cord injury medicine in the academic setting. So thank you so much for joining us today.
Yes, they got to see Benecia at the conception. So.
That's right. Yeah, I think Dr. Sikka was like my first rotation on spinal cord injury. So
yeah.
Right.
Really come out of your shell since then. I'm so proud.
I tell people all the time, I said, Sheena and I are just like each other, except for like at the extremes. Like our mind, it works exactly the same, but I'm like out here and she's. Well, if you guys will tell us a little bit about yourself, Dr. Sikka, tell us where you're from, tell us a little bit about your training, and then your current practice now.
Sure. So I'm from Tulsa, Oklahoma, and so not far from Dallas. I went to undergrad at Washington University in St. Louis. And so I was eager to get out of Oklahoma. So I went out of state and it was a good experience. It was intense because it had a big pre-med class, but luckily I was able to double major and do some philosophy and psychology and things like that. And then I came back to Oklahoma and I went to OU Med School. And so OU Med School was good. The thing about OU Med School is there's no really PM&R sub-Is or rotations, and not a lot of people know about PM&R. I was in med school there. There are some rehabs, but there's not anything really associated with the med school. So I knew about PM&R, so I did some away sub-I rotations. And funny, a couple of my classmates was like, what's PM&R? What are you, when I decided to do it. And they actually, there was 3 of us that ended up actually going into PM&R, which I don't, from graduating classes from OU, that wasn't really, so it wasn't, I think it's definitely gained its popularity, but in Oklahoma in med school where I was, it wasn't really well known. And then I went to Detroit, Michigan for residency, Detroit Medical Center, and that was a good experience because you saw a lot. So there and pretty much debated, I was pretty much debating whether I wanted to do TBI or SCI. I mean, I like neuro, so I ended up choosing SCI, and I went to Boston for my fellowship, which was a really good program because I got to work both at the VA as well as an academic, a more private institute, so at Spalding. So I kind of had both those sides in my training to see kind of the more chronic injuries at the VA and then the more acute injuries at Spalding. And then I worked in Cleveland at a VA for a few years and then made my way to Dallas. So I've been in Dallas at Baylor Scott and White now for over 7 years now, which is probably the longest I've ever lived someplace since I was a kid. So, yeah, but it's been good. It's a great group of people, so that's why I'm still here.
Awesome. Dr. Chung, tell us a little bit about yourself.
So for me, I actually grew up in Southern California, suburbs of LA in Torrance. Pretty much spent my whole life there. Went to UC San Diego for undergrad and decided, med school was the route I wanted to go to. So I went to Touro University, California, which is up in Vallejo, which is an osteopathic medical school. That was an experience. It was fairly new school still, so the structure-wise, there was a lot of things going on, and It was great though. I got to meet a lot of, I have made a lot of friends from there. Got a chance to do several away rotations in PM&R. Got to check out different places, which ultimately led me to Chicago, actually. Initially, the plan was to come back to LA for residency, but when I spent some time in Chicago doing an away rotation, kind of saw this world outside of Southern California. And Chicago is an amazing city. It was a lot of fun, a lot of great places to eat. I had some friends out there, so decided to go out there. So I did my internship out there at Illinois Masonic Medical Center, which was a DO program at that time, which unfortunately doesn't exist anymore. And then I went to Rush University for PM&R, which was a great experience. Made a lot of good friends there, a lot of good mentors. It's kind of similar to, I think, I always tell people, it's kind of like the Baylor residency program, very similar personalities. They work hard, but also know how to have a good time outside of work. Attendings are fun to work with. So kind of did my residency there and decided to go into SCI, and I didn't want to leave Chicago quite yet. And fortunately, there's a good SCI program out there in Chicago at RIC, now known as Shirley Ryan. So got to spend a year out there, did a lot of training, a lot of learning, got to train with a lot of great physicians. And then somehow ended up in Dallas. I needed a job, and there was an opening out in Dallas, an acute inpatient job that was primarily SCI, and decided to take the chance and didn't regret it at all. It's been a great experience. For me, it's been almost 6 years, or I guess a little over 6 years since I've been here. I think my start date was October 6th, so it'll be 6 years very soon. And then
I think you started when we started.
I think so.
Yeah,
I think it was,
Yeah, you were like the new attending. Yep, I remember.
That's where I'm at now.
Great. And so both you guys mentioned that you were able to do a few rotations in PM&R as a medical student. And Dr. Sikka, you said that you had already known about PM&R, and we've talked about a lot with our guests in the past that oftentimes medical students don't even hear about it until, late PGY3, MS3, or, their fourth year of medical school. So how did you guys hear about PM&R? Just briefly, why did you decide to go into it? And then when in your training did you decide to subspecialize in spinal cord injury?
So for me, when I was in med school, I went to med school because I actually wanted to do sports medicine. Benecia, I was supposed to be you. That's supposed to be my job in the future. So I went to med school for that. And one of my, I guess, quote unquote mentors at that time, he kind of helped me along to kind of guided me through med school and just kind of gave me advice. He brought up PM&R, and something I never knew about. Told me it's a field that could be a good fit. You can get good training in MSK, and there's good opportunities out there for you if that's kind of the field you want to go into. Because I knew I could go through it with family medicine, but he thought this might provide more opportunities in the future. So I got a chance to do a few away rotations, and it was a great fit. I remember coming back from one of my rotations. The first day when I was in Chicago, I told my friend, they're like, "How was it?" I'm like, "Man, when you buy something like a new shirt or a new shoe and you put it on, you're like, wow, this really fits really well." It just kind of worked out for me, and I was like, this is kind of what I want to do. It's exactly the type of field I wanted to go into. Kind of made me enjoy medicine compared to some of the other rotations I did in med school. So I decided at that point that's kind of the route I wanted to take, and got to experience different types of rotations. And when I was in med school, I actually never had a spinal cord rotation. I remember did TBI, stroke, ortho clinics, but SCI was one field I actually never had any exposure to. But it was my first rotation at Rush. I was at a county rehab program, acute spinal cord injury, and just kind of opened my eyes to kind of this new field that I'd never been exposed to. And I was like, this is kind of interesting. You get to work with patients, you get close interactions with different therapists and nurses, you get involved with different family members, you develop a good relationship with people. So I kind of kept that in the back of my mind and did a sports medicine rotation in my PGY 3 year, decided that wasn't the right fit for me, and kind of decided, I looked back at some of my options and I realized spinal cord was kind of the route I wanted to take. Surprised a lot of people, surprised me, but I wanted to be in a hospital setting. I knew that. I wanted to work with I like being in an environment where you work with different teams, different therapists, nurses, and it just kind of made me enjoy medicine. So I decided spinal cord was a route I wanted to take.
What about you, Dr. Sikka?
Yeah, so I knew about PM&R since I was born, basically, because my mom is a physiatrist. So that was a little different. But everyone thinks I went into PM&R because of my mom. And, you know, as much as I love my mom, that's really not true. I probably did everything else because that's what my mom did. But, you know, I can't say I didn't have some exposure to it. Definitely when I, you know, my mom worked a lot and we lived in a small town and there wasn't really a lot of PM&R. So she went all over the place. So I would go on the weekends around with her and stuff. But, you know, I didn't really have a good understanding. But I was always fascinated with pretty much like neurology and stuff. And I really was fascinated by the brain. And I thought that's what I really wanted to study. I did like research in it as an undergrad. I, you know, did my second major was something called PMP, which was like a neuroscience type major. So I really thought I'm going to do neurology. And then when I was in med school, I actually worked with a neurologist that was a neuro rehab doctor. So she did neurology and then specialized in rehabilitation. So that's also another avenue that a lot of people don't always know about in neurology. So she was, you know, as much as I liked neurology at first, just like the theoretical side of it, I found like a lot of times in diagnosis, half the time you can't really even pinpoint the diagnosis. And you're ordering a lot of tests and you're trying these treatments, but then the patient leaves. You don't get to see what happened. You don't get to see their recovery. You don't get to see, you don't really have to get to know them or see like the whole. You're the consultant kind of going in. So I worked for her like with a week or two, and then I ended up doing some research with it. And so I got to see more like her clinic and her being able to follow up on it. And so I was like, you know what? And then I did my away rotations, and I was like, well, my mom will be happy. So yeah, for me, it was the perfect fit just because I did like that neuro end of it, but I ended up liking the musculoskeletal part too, because that's a lot of it. And it's a lot of what you see with any person with chronic conditions or acute conditions even. So, and I wanted to deal with like a more holistic approach to medicine. So for me, it was a good fit. And then when I went to residency, I had a really good mentor, Dr. Alfonso. She was kind of like our second mom. And she was just, you know, when people are really passionate and enthusiastic about what they do, you're very inspired by it. So she's very inspiring. And I really like TBI too, but it was just kind of what was a better fit, and kind of like what Dr. Chung said, SCI just fit me more. Although I did in my fellowship do a couple months of TBI rotation. And I am board certified in TBI. But we do see a lot of milder cases, but we do see a lot of dual diagnosis. So that's kind of how I ended up in spinal cord. I'm sure my mom likes to take all the credit, but I can't give her all the credit.
No, that's awesome. So obviously you guys work in an academic institution. Dr. Sikka, you had said you previously worked in the VA. I know I do a lot of acute care consults, and I'm a strong advocate of having acute spinal cord injuries try to go to an academic setting for rehabilitation, because I've seen where they've gone to a community setting and it's followed up with us down the line. They'll come into our outpatient setting and we're like, what did they teach you about a spinal cord injury? And like all of us training at Baylor, like, you know, it was such a great program. So did you guys always know you wanted to be in an academic institution and do some teaching? Dr. Chung.
For me, not really. I mean, I don't think I went into had that mindset going into residency. I think it just kind of happened organically. you go through training, and during residency, you get to work with medical students. We held workshops with them. I remember doing MSK workshops with the first and second year medical students. And kind of through that, you just kind of get involved in teaching. And I was like, oh, this is kind of fun and interesting, and kind of get to, give some insight and giving feedback on what you've learned. And, you take different ways of, you were taught different things and try to pass that on. And, fortunately, like I said, I had a chance to work with some really good educators and physicians that really knew how to push me in the right way, kind of got me out of my comfort zone and made me think differently, made me kind of challenge myself, which I really needed. And I kind of enjoyed that. So for me, it was all about, I kind of want to pay that forward. It was really good to learn that way. And I think the hardest part coming out of training is trying to take everything you learn and it's kind of seeing how do I pass that on to the different medical students and residents in a way that's going to be most effective. I think it's something that I find it's very hard, and I work on it all the time. I think being an academic attending, it's very difficult, and it's something that I enjoy because it is challenging, and I kind of want to continue to improve on that. But you can't teach every resident medical student the same way. That's what I learned. You got to try to tailor the rotation to kind of each resident, kind of see what their goal is. And this is my, I think, fourth or fifth year since having a resident. I don't think I had it the first year I was there. But it's every year I kind of change my approach, because I think back to what worked and what didn't work, and trying to figure out what works best and how they can kind of get the most out of the rotation. Because to be honest, not everyone wants to go into spinal cord, and I get that, and we all know that. You can kind of tell just by the approach. So the goal is, and what am I trying to get them? What do they want out of this rotation? Is, I think, the most important thing. So I try to make sure I don't force things down on them. Try to make it just something they can enjoy and get feedback. And if things don't work, then I try something else next time. So yeah, I think academics is, being part of spinal cord injury, I think for me, I wanted to be an academic center because I think you get to see more, especially early on. I get to see a lot of cases. I think patients are looking for kind of the top spinal cord rehab programs wherever they live. They want the best possible outcome. And being in an academic center, I get opportunities to work with other consultants. You have resources that aren't available in, some smaller rehab units. So if there's an issue that comes up, I know I can call different consultants and ask for help and guidance. Do you have wheelchair clinics that's not available in certain places? You have spinal cord specialists that you get to work with in therapy that aren't available in other rehab programs, and different equipments we have here. And it's just that it just allowed me to kind of have the best opportunity and gives the patients the best opportunity, in my opinion.
Yeah, I think for me, I trained in academic places, and even when I was at the VA, both in Boston and Cleveland had a strong academic collaborations. So even in Cleveland, I worked, I helped do modules with medical students in their first and second years, and we had residents and fellows, and we worked with other other acute non-VA SCI centers. So I think I've always been in that setting, and the thing I've liked about it is that you always have to keep learning. Like you're a lifelong learner. And I think with teaching, it's not only that you're helping teach, it's like I learn a lot by teaching. So selfishly, I like to do it because it keeps me on my toes and updated. And I like the research that goes on in these institutions and keeping up with that, and how does that then research apply clinically? How can, what are collaborations that you can do that you can then apply clinically? And that's what really moves the field forward. And that's what makes it exciting. So you learn things and stuff, and yeah, you can, know the Asia exam, and you can do the Asia exam, and you get faster at it, and you don't have to have the big sheet or, but there's other thing like, okay, well then what other outcomes do you look at where this is more meaningful? Or So I think that's what I really like about being in academics versus like a purely private practice. It's just that affiliation with schools and teaching and research. And yeah, other specialties that are also interested in that and how you can form collaborations. Because that, I think, then you're always learning and you're challenged. And so I never feel like, oh, I know it all now. Like, it's like I'm constantly learning. And that could be even from a new resident, and they just ask me a question and I'm like, oh, I've never thought about that. We should think about that and look into it. So I think it makes you ask questions. And when you're in an academic institution, you can have that support to try to answer those questions.
That's great. You guys are both excellent teachers. I remember like being in Dr. Sikka's office and going over some PowerPoints that you had prepared, and then Dr. Chung with his oral exam preparations. Remember those?
Yeah. And he'd be like, okay, so you're going to
so
give
strict.
me tomorrow. Yeah. I'd like, yes,
Stone
I am.
face.
You were so good. He was like, Dr. Chung, I'm so nervous.
And then what? And then what?
Right. That was good though. I know I have a medical student now. Omar is a big proponent of mentoring and having us take students. And I'm like, oh, it's so much pressure. I'm like, I'm responsible for their education. I'm like, and this is going to be their impression on PM&R. So like, I can't mess it up. It's a lot of pressure. It is.
Yeah.
No, you guys are excellent. You've learned a lot from you guys for sure.
Thank you.
And so we've talked about this before, Benecia, but we stress it so often that spinal cord injury is really, we think, like the foundation of PM&R. It has everything in it, talking to families and patients about very hard diagnoses and outcomes. And then you learn a lot, even though it's like spinal cord injury, you learn a lot about the musculoskeletal and neurological symptoms. Like,
at what we do because of our SCI foundation for
the
sure.
ASIA exam, just kind of knowing how to properly test those muscle groups. And it was actually my first exposure to PM&R. I did the RIC externship between first and second year of medical school, and I was on the SCI floor. And so I thought going into residency that I wanted to do spinal cord injury. So it's always had a very special place in my heart. So obviously this year it's different when it comes to students and applying to residency programs. So I don't know if you guys are even taking any students in person, but for medical students, what advice, Dr. Sikka, would you give to them, on how to excel on their rotations? And then for Dr. Chung, if someone's interested in spinal cord injury and wants to do a fellowship, how, what are some things that they can do to make them a competitive applicant for fellowship?
Yeah, so with medical students, it is, I think we do realize it's tough because we do get a lot of medical students, and they're from all over, because some places do have limited rotations or exposure to PM&R. So really, and they're, you're competing with people to get into those rotations too. So really, I think it's we want to make sure when we have medical students that we're giving them good exposure to the breadth of PM&R, which is quite diverse, right? So there's so many things you can do within the field. And that's also why I like the field. I mean, I've known many of my colleagues who've actually switched specialties within the field during their career. So, I mean, that's pretty neat. So I think being able to get a good breadth of PM&R, knowing that you're not going to get to know every single thing and all the details, especially if you're there for a month and you're on a week rotation per type of specialty. So for spinal cord, the basic thing is really realizing, okay, one is the neuroanatomy, neurophysiology, like how does you doing an exam, even though it seems like a pain in the butt exam, how does it help you determine the eventual outcomes for the patient, and how does it help you help them the best way possible? So that's really why we do the exam. It's not just to put like a score on a sheet or to build, it's, I tell folks when I do is that this is going to help me figure out what we need to do to help you. So I think knowing that and how, understanding if you know the basics of that neuroanatomy and physiology, how then you can eventually go to get the bigger picture. So with spinal cord injury, it's not that just someone is paralyzed or weak or can't walk. It affects their whole body, right? It affects pretty much every organ system in your body, from emotional, cognitive to, bowel, bladder, intimacy, all of that. So you really have to address the whole person in spinal cord. And I think, and that's really in any chronic condition, but really that's what you should do with anyone. But with spinal cord, because it does affect so much, and you have such limited time with these folks, and it's such it's such an overwhelming process because your life is just completely upturned suddenly. You really have to work with a team. And so that would be the other part. It's like, yeah, I know the basics and how it affects realize how it affects their outcomes, but then also look at how you need to work as a team, and what different members of the team bring, and how to collaborate in that sense. And I mean, that's really the fun part of the field, is working together as a team, and then seeing the results. So I mean, that's because they're only the medical students we get a lot, but they're like with us for a week. So it is tough. Because like I said, there's a lot we have to address in someone who has a spinal cord injury.
In a short amount of time, like you said.
Right, yeah. So I think just realizing that, and so, that's why most of us usually start with the basics, and that's just the exam, but then try to give you an exposure to everything that is affected by it.
Mm-hmm.
And
I told students.
Recognize it, because we know whether you're a med school student or you're a resident or whatever, we know there's a lot of people that get a spinal cord patient, they don't know what to do. They don't know what to do, these patients. And you may be the first person realizing they need something that could be a huge impact in their lives. So you could be the medical student on a trauma rotation that has had spinal cord injury and realize, hey, this guy has like all this bowel incontinence and skin breakdown because he needs to be on a bowel program because he's a spinal. You could be the first person who knows that. Or to check if they're retaining, or, so you don't have to want to do spinal cord, but there's very high likelihood you could be the first person knowing what they need.
That actually kind of blows my mind. 2 points that I want to make. The first one is, yeah, like people don't realize about the bowel and bladder, even like in the medical field, like they realize, oh, they can't walk. I'm like, but did anyone realize that they can't use the bathroom? Like, you have to address that. That was the one thing I was telling you about my other patient. I was like, did anyone check to see if she's had a bowel movement? The last time she was, I'm like, she's going to get a bowel obstruction. Right. And the second part is like, yeah, you might get maybe 4 weeks with the spinal cord patient. I'm like, in that first week, I tell my students, I'm like, they're still coping with the fact that they've had this horrible trauma. So it's like the stuff that you teach them in that first week, they might not even, process, because they're still trying to process the trauma that has happened to them and the way that their life has changed. And that is huge. So I think it's awesome that we have neuropsych at BIR to help address those things, because it's literally life-changing for not just the patient, but for their entire family. Sorry, I just want to make a point.
No, it's true. You form fast relationships with your patient, and like I said, it's really like a team. They may bond with one member of the team more than another, but as long as they're just is someone, but they have to kind of put their trust in you fast.
Mm-hmm.
You have to be respectful of that, for sure.
Yeah, absolutely. So Dr. Chung, what advice would you have for someone who wanted to go into a resident that wants to go into SCI?
For fellowship.
Mm-hmm.
So I always tell people, med students and residents, that if you really want an SCI fellowship, you're going to get one. I checked today, mainly because a lot of spots go unfilled every year. So I checked today just to see how many programs there were, because I wasn't sure. It's actually a lot more than I thought now. So there were 24 programs, and a lot of them have more than one spots. So probably I'm going to guess maybe there's 40 positions available every year if they have funding. And I looked at how many took boards last year, and there was only 18. So even last year, they went unfilled, multiple positions unfilled. So if you really want to do SCI, you're going to get a spot. Now, it's going to depend on where you want to end up and what kind of program you're looking for. So that's something you're going to want to consider. Do you want 100%, acute-based rehab? Do you want a mixture of acute and VA like Dr. Sikka had, or do you want 100% VA? So that's something to consider when you're applying for an SCI fellowship. But to become competitive, I think there's some things that are a given. You're going to want to go to conferences. There's two big spinal cord conferences: ASCIP, which is typically held in the fall, around September, and then Asia, which is held in spring. I think it's usually either April or May, just kind of depending on the year. So those are the two big spinal cord conferences, and you're going to want to go to that. You're going to want to try to present posters, cases, and just network there. It allows you to meet different program directors, meet current fellows, meet different therapy staff members. You can meet nurses. Sometimes program coordinators will go. So that's your opportunity to kind of meet people, kind of figure out where the programs are, and see, is this going to be a good fit for me? And another reason you're going to want to go to a conference is for SCI. All their interviews are typically held at ASCIP conference now, which is held in September. So if you're going to apply to the program, you're going to have to go to that conference more than likely. So it's a good idea to kind of have that in your mind. You definitely want to check out the conferences, maybe as a third year, present a poster, and even non-SCI conferences. So, AA PM&R is a big one. I remember going to the job fair there my third year and meeting the program director at RIC, and I got a chance to speak with Dr. Chen, and he gave me a full breakdown of the fellowship and kind of what, how they approach their fellowship. And it was really good. I got a chance to meet him. And so when I met him the following year, he remembered me, and that was helpful. Networking is a big thing. You're going to want to, you want to know about these programs, especially because a lot of times you're going to apply for these programs sight unseen. You're not, because it's a match now, it's a common date. So most of the time you're doing these interviews in September, you have the match, and then you're into the program. You may have no idea what the program's about. You may have never been to that city before. So if you know fellows that are there, you can reach out to their fellows there and get some information, find out how their year has been, and kind of get some feedback on what they liked and, what the rotations are. Because, are you looking for a rotation where you're kind of like a residency repeat, where you're kind of doing inpatient stuff, but you're not allowed to really do anything? Are you looking for a fellowship where you're more observing everything and just trying to learn as much as you can? Or are you looking for a fellowship where it's just 100% you? You're basically running a mini service as a sub-attending, which you're attending, kind of looking over and helping you. So kind of trying to figure out what you want to do. But I think, the more networking you do, it's going to make you more competitive. Obviously, research and presenting posters is going to help you, but they're not looking at board scores. They're not looking at exams and things like that. So just kind of getting out there and just getting to know people is going to really be beneficial.
Awesome. And we kind of touched on this next question. I was going to say, what's your favorite part about working in an academic setting? And then can you guys give us kind of a look at what your day looks like? How many patients you typically carry? When do you start rounding? How your admissions work, and when you take call, just so for those who are interested in working in academic rehab, they know what to kind of expect.
Yeah. So what was the first part of the question?
I'm sorry, your favorite part about working in academics, and you kind of already mentioned all this, so that's why.
So I think I kind of mentioned that I do like the group that we have. I mean, I think I can really say that we're all really passionate about what we do, and it's nice to be able to, if I have a crazy case and I'm not sure about something, I can go to Dr. Chung and talk to him about it, and we can bounce ideas off each other. Or if I have a case where they also have a TBI, I can go talk to Dr. DeBiel and bounce ideas off of it. So I do like that part about it too, that, we're very open door and collaborative, even as colleagues. And then as far as my day, I don't know, my day is probably a little different. I probably start later than most, but yeah, I probably start around 8. And I like when I round, I do like to, sometimes I even go back in the afternoon. I do like to see my patients in therapy. Sometimes I feel like I can get a lot about how they look in therapy versus just seeing them in bed. So at least that's the excuse I tell myself, so I don't have to get up as early, but I like waking them up. But yeah, so I probably start around 8, and then, I think we both carry similar loads, but we take about usually around 12 to 15 patients. Now, I think our highest, or what we can handle just for purely spinal cord patients between 2 services is about, like, once we're getting to 24, 26, we're pretty full. So that being said, we do take patients that aren't spinal cord on our services. So we do take like laminectomies or hip fractures or sometimes some debilities. So we can have a mixed service that way, which isn't bad. Like it helps keep up your general PM&R skills. So, and then our admissions, I think for our service, we like to have more of a heads up for our admissions for spinal cord, because we kind of have to plan some stuff even when they come in. And so we tend to know, at least a day or 2 prior to what kind of admissions may be coming in, because we're reviewing most of the referrals. And so, but most of the time, we get at most probably 2 admissions each. Sometimes there might be a 3rd one, but for spinal cords, there'll probably be 2 spinal cords each a day, but we don't get that every day. So our facility sees about 200 spinal cords a year, but that's pretty much 50-50 traumatic and plus non-traumatics. So we see a good amount, but some of them are definitely not as severe as others. And then we get spinal cord disorders. So we see the MS cases of spinal involvement or transverse myelitis, or even like a bilateral amputee that's like functioning like a para. So we get those on our service, so because we can better equip them for what they need initially. So yeah, I think I think when I first started there, it was kind of crazy and I would have late days, but now I feel like with our admission team and us trying to get I think both Dr. Chung and I are trying to be efficient by getting a heads up on who's coming in earlier in the day and prepare. So I feel like I can have pretty reasonable hours of not bringing work at home as much. Daun, do you have a different?
For me, favorite part, and it's kind of similar. I mean, one, it's, you get the type of patients I get to see. These are acute cases, and that's something I knew I wanted to see, especially coming out of training where, that first few years can be a little nerve-wracking, and, you're always questioning your decisions if it's right. And it's kind of hard to trust your judgment is correct, and you're just trying to learn as much as you can. So I wanted to see as many cases as I could, acute setting. So the type of patients I get to see is something I really enjoy. And like Dr. Sikka said, if you're in a academic, acute rehab program, rehab center where there's different types of programs in there, if there's a TBI patient, debility questions, there's different doctors you can ask and bounce ideas off of each other. When there's TBI questions, I'll ask Dr. DeVille. If there's medical issues going on, I know I can call some of the consultants across the street, and they're helpful. So that's what I really enjoy being in acute rehab, an academic facility, especially ours. It's, we're a small group, but we work well together. And there's questions about different things or different cases that I see that's kind of unusual. You can kind of bring it up and you get feedback, and everyone's very helpful. And day to day, it's kind of pretty similar. I mean, I start a little bit earlier, but that's only because I was peer pressured when I first got here. For whatever reason, the doctors in Dallas love to start working early.
At least,
Doesn't make my day shorter.
So,
Make my day shorter.
no, and I would come to work at 8 o'clock
and you be shamed.
And I felt very pressured because I felt I was behind everybody. So I was like, okay, I got to come in a little earlier. So I start my day a little bit earlier. But it's not bad. I mean, I start around 7:30-ish, and then kind of like she says, you see your patients, and you have 12 to 15, and patients we see typically are spinal cord, but different neurological conditions too, you know, MS, GBS, CIDP, things like that are also kind of patients we work with. So it's, work hours aren't bad. I mean, I think most places are, it's how you make of it. And, I feel like I'm pretty good with managing my time every day. So even hours coming in a little later, I mean, I think everything's pretty reasonable. So.
I remember and I'm sure all the residents that you've had could tell you this, like Dr. Chung, like, okay, we're going to split the notes or start from the bottom, you start at the top. And we would be going, you'd be like, how is he so fast? Like you would be 3 in and he would be like 7. And you're like, how did he do it so fast? So I remember one day I was like, he is not beating me today. So I was like, I gotta go and finish these notes super quick.
That's something I've also learned and I'm working on, kind of slow down a little bit. Things you learn.
I was like, he is so quick with these notes. What is he doing? It was so funny. But yes, that is one thing I've learned is to try to definitely get your notes done. That is the worst part of my day.
Be efficient.
But,
yep.
More
about it's not about getting your notes done. It's about managing your morning because
yes,
afternoons you just don't know. If you get 2 tetras that are coming in at 2 o'clock and then another one at 3 o'clock,
you're gonna be there.
Usually be 3 or 7 if you don't manage your day correctly. So for me, it's first thing I had to get out of the way in the morning is to get those notes done.
Yeah, you feel accomplished.
If you get those done, do it correctly. Obviously, you're not rushing through them.
Yeah,
you're doing it in a correct way. Once you get those done, then you have your day to kind of follow up on different things. I can go see patients again. I don't even think everyone realizes it. Sometimes I'll make a second loop in the afternoon, just kind of check in on things, and not everyone knows that because I kind of.
Oh, we all know.
I kind of do it. No, but I'll do it and then just kind of make sure they're okay. So that's something I learned in residency. One of my attendings would always do that. Now I don't do it for all my patients, but I do try to kind of see certain things and check in on them in the afternoon and make sure things that were issues in the morning aren't issues again.
No, that's awesome.
I think like when you have like a true spinal cord admissions, they're not like 20-minute admissions. They take a while, not just for the exam and stuff, but also, so it's like the chart review takes a while because they're usually kind of complex and we get them from all over. And then the actual exam, and then you have to do a lot of counseling right when they get there. And there's a lot of education, right? Like we have to start bowel program day 1, and have them come with like their bellies are so distant. So we have to start like night 1. And so you're doing a lot of education. So it's not a fast turnaround type of admission, like a hip fracture or something. And then, like I think you check in on, because you can't just see them in bed. You have to be able to see them through the day. And then also provide the education you have to provide when they're with you is a lot. So it's just about being able to have those conversations, whether it's one day about their bladder management or the next day about their skin, but you have to be able to have those conversations and educate them on it.
Yeah, awesome.
But what really kills your day is meetings. It's those meetings, and that's the hardest part, is how to get out of all these meetings.
How to get out of the meetings. All right, well, now is usually the time where we have some questions from the audience. So if anyone has anything, please type them in the comment box. But I have a question for y'all. So obviously with COVID, everything, has changed, especially initially. And you had mentioned that there's a lot of counseling patients when they, are first admitted. So was there, and I don't know if BIR did, but I know some, hospitals weren't allowing any guests or any family members, in for that the first few months when we were going through all this pandemic. So how was your practice affected? Did you have those issues come up in terms of, the patient was just by themselves and they didn't have any family in there with them?
Yeah, it was really tough. Not even just for the education piece, because they feel so isolated and they're going through so much. So we did limit visitors. Our hospital had staff that went around to offer ability to set up FaceTime for folks so they could talk to their family, especially ones who didn't have technology and they couldn't use their hands and things to do that themselves. So that was something they implemented that really helped. We quickly videoed some of, because we have something called START classes, which was in a classroom setting where we went over core topics with the patients and their families, and we couldn't do that anymore. We couldn't gather. So they made some quick videos of these core topics that they could take in an iPad and show them, or email a link to the family members. We communicated resources a lot with the family via email. I myself had a lot more teleconference family to try to, I think both a lot of all the physicians really were calling families a lot more, even on a daily basis for updates. So it was a lot more work almost, in a sense, having to communicate with, you know, all our patients' families plus our patients. And then there was a lot more one-on-one therapies. So that was a change, because there was, before we had, like, for instance, for stretching, we would have mat class in the morning. So everyone would get kind of stretched and maybe one or two therapists could help. But now we had individual therapists who had to go stretch, and we were trying not to have, we're trying not to cross coverage therapists. So like a therapist would have their set of patients and only see set of their patients and not cover, you know, try not to have that coverage. So you're not. So in some ways it was harder because we couldn't use all the equipment that we had in the gym. In some ways it was, we noticed, they ran some trends, and we noticed, like, for instance, our ADL scores went up faster, because I think we were doing in-room therapies one-on-one. And so you saw better progression in the ADLs initially. And so our support group is difficult. You know, we have that even for our community members, plus our inpatient. So that was affected, and setting up Zoom and people being able to use that. It's not only that, it was them being able to use that technology is really hard. So there's that, trying to walk them through that and see if there are people to help set that up. There are certain things we couldn't do, like we used to bring in vehicles so they could see different vehicles and modifications, and we had to kind of do that online, show pictures and more individual. So it definitely affected how we were able to provide education. It did help us try to speed up the process of having more of a web-based education curriculum that we could provide. Not that we want to play with in person, but just as now as a supplement for the world we are in today. So, and like, you know, if you talk to outpatient, they had to do more telehealth, but for our population, that's actually been good. We've always wanted that. And so it's kind of that process due to their access to transportation and other needs they have. So there's a lot of good that came out, but it's definitely been difficult. And yeah, I think we were all trying to figure out at first, and just what the best way to communicate and provide that to people, even communicate within the team, you know. I like, yeah, my email box just was endless.
Sure.
Absolutely. Okay, well, oh, someone just had a question.
We got a question, yay.
Yeah. You want to read it?
All right, this is from Cody Mutter. So he has a question for Dr. Chung and Dr. Williams. Being a DO, do you find yourself utilizing your OMT skill set in your field very often? I'm an OMS2 at Nova Southeastern and have been interested in a career path, particularly in PM&R.
For me, no. Unfortunately, I think time is always the hardest thing. So just finding time to do OMM, OMT, that was kind of a challenge in residency, just finding that time. But so I don't actually do it in my practice. I remember in residency, there were times that some of the, I guess they were the fellows, right? The OMT fellows, they would come through, and you know, sometimes they would want to do certain things on SCI patients, but you have to be kind of careful just because they just had spine surgery. There's a lot of instability. So you really want to be careful not to do kind of anything in the spine area. But but they'll do. I remember some of them would do like soft tissue release, kind of help with trying to see if they would help with pain, things like that. But for me personally, I don't do it in my practice, or I'll use it on my patients.
Yeah, same thing for me, Cody. It's typically like a time situation because my visits are set up like every 15 minutes. So every now and then I might do like a piriformis release or something like that if I'm fairly sure that's what the cause of their pain is. I know in my sports medicine fellowship, one of my mentors and professors, he was a DO as well. And we had, I think, 3 DOs where there were 7 fellows. It's the largest sports medicine program in the country. There were 7 of us, so 3 of us were DOs, and they would actually have OMT clinic for the TCU athletes, and they loved it. But that was also additional time outside of our traditional training. Oh, hi, Hayden. Hayden's joining us.
You should be studying.
Dr. So last question, if no one else has one, we like to ask all of our guests this. If you were not a PM&R physician, what would you be?
Is that it's like medical or non-medical?
You can do both. We've had people choose both. For sure non-medical, and if you want to choose a different field, you can.
Well, if I wasn't in the medical field and I was a better writer, I would love to be in sports journalism. I think that'd be really fun. Especially nowadays, there's so many different ways to be involved in it. Kind of like more of an investigative sports journalist, I think that'd be really fun. Sports is still a big part of my life. So, but as far as medicine, I probably would have gone family practice because, like I told you, my initial dream was to go into goal was to go into sports medicine, and we can kind of go through it with the family medicine route. So I would have done that, I think, because I enjoyed my family practice rotation too. So.
Dr. Bayazatillo just signed on. Hi, Dr. B.
Dr. B.
Dr. B.
Dr. Sikka, what would you do?
I think ultimately I still would have liked to do something in like a health provider field, whether that would have been like social working or something just to help people kind of manage or guide through their chronic illness. But on a fun basis, probably like, I don't know, have a coffee shop or be a professional dog walker. That's what I was
gonna say. Yeah,
dog. Or have a dog ranch or something.
If I could quit my job today and do a dog ranch, I would.
Veterinarian. I was like, I don't think I could do that. I couldn't the animals be sick, but yeah, something. But I still think, I think ultimately what guided me to this was to do something to help people manage their overall quality of life. So something that would help their quality of life.
Yeah, no, we have such a fun field. So we thank you guys for taking the time out on a Sunday and joining us.
Yeah, thank you so much. This was so great to see you guys.
For guiding us to my first Facebook Live.
Yeah, y'all did great. I know you guys aren't on social media, or you don't do a lot on there. So if anyone's watching and they have any specific questions for you guys, what's the best way that they can contact you?
You just give them my email, my Baylor email.
Okay.
Same Baylor email.
Great. All right.
Sounds good. So you guys follow us we have social media, as you know, at Facebook. We're on the Virtual Physiatry Mentors, and then on Instagram it's at the.virtual.physiatry.mentors, and we're both on Instagram. So yes, follow us on there if you have any questions. Sheena and I were talking earlier, we already have 24 episodes. So sometimes people will ask us questions and we'll be like, hey, just refer to the video because I guarantee you we've talked about it. Next week, we have Dr. Amy Ng. She'll be on. She'll be talking about cancer rehab at MD Anderson in Houston. So we're excited to have them. We've had a lot of Instagram takeovers as well. So other programs, if you're out there and you're watching and you're interested in taking over our Instagram for the day to highlight your program, it's the perfect time to do this as interview season is approaching. So yay. All right. We're signing off live.